your life.
Hi, everybody. It's Dr. David with another Ask Dr. David live session. Thank you for everybody who's been continuing to join us for these sessions. It's been lots of fun. Hopefully, we get some new people joining up with us as well. Um, this is a fun session for me because I get to be a little bit more extemporaneous. With you kind of being able to ask questions on the go. I do very much enjoy kind of like being put on the spot for things like that. It kind of makes for it both excitement and fun for me, and hopefully it will be for you. Now, joining us off screen is Shari Kulanu, who is both the executive producer of the show as you probably know, my sister, and she's going to be feeding me the questions as they're coming in and the questions as we go along. We always do start with questions from our Patreon subscribers and from our patients, and then we kind of move along. So please, if you haven't already joined us on our Patreon page, please do so. In addition to having this perk here, we do have exclusive content there, additional holistic protocols, etc. there. So please join us there. And of course, if you haven't already subscribed to our YouTube channel, please do so, as well as join us in our other social media platforms. Okay, so Shari, I know that you have some questions for us, and so here we go. All right, so question: do Epsom salt baths? So I'm actually reading it. She's hitting me up on this little chat button here within our software program. Do Epsom salt baths actually help to detox the body and reduce inflammation? If is there a certain amount of salt and time that should be used, and how many times per week should they be done? That's a really good question. Now, Epsom salts has been one of the very, very first treatments that I started to use. This goes way, way back to my first days of starting working with children with autism. And what we had learned back then is that there was a Dr. Rosemary Waring who was in England who had discovered that children on the spectrum had lower amounts of sulfate in their body than children who were not on the spectrum, and had furthermore went on to discover that they were spilling it in their urine for some reason. Now, there were certain symptoms that, and we continue to ask these questions, but some of the symptoms of a sulfate deficiency are things like inflammatory reactions, asthma and allergies, night sweating. That's a kind of an interesting symptom, as well as what is called keratosis pilaris, which are little like red bumps, kind of like little chicken flesh that can appear on the backs of the arms, as well as sometimes like on the thighs as well. Now, why is this important? So, Epsom salt itself is magnesium sulfate. And when done as an Epsom salt bath, in water as hot as possible without scalding the individual, which the heat opens up the pores and it allows the magnesium and the sulfate to absorb directly into the body. And some of our body's most important proteins of detoxification, in particular N-acetylcysteine, which then goes on to make glutathione, it requires sulfates to be there. There's other important amino acids and things that the sulfate is made from. Now, we know that N-acetylcysteine and glutathione are super important for both reducing inflammation as well as um, helping us detoxify. So you kind of get a two for one there. In addition, you want to call it a three for one, magnesium. Magnesium has such wonderful calming properties. Some people take magnesium orally for that, but some people that can get like a diarrhea from that and their GI tract can't handle it. And if it's not going through the GI tract, it will not have that same effect. So we get both the calming effects of the magnesium, the detoxifying and anti-inflammatory effects from the sulfate in one grand solution. It's certainly safe for anybody to do. Now, I have had a few people who have gotten some dry skin, especially if they have eczema, that they could get some dry skin afterwards. My advice in that situation would be to apply a moisturizer as soon as possible after coming out of the bath, and that should take care of it. With any time with eczema, if the skin is dry, that means we're not being moisturizing enough. Um, what I typically tell people to do to know whether it makes a difference or not in the first place is to do it for at least a week every single night. We aim for 10 to 15 minutes, and we want to make sure that the water is as high up the body as possible because the more skin exposed, the more of a dose we will get. And our trunk has the most skin surface. And so if we're only up to our waist or up to our belly, we are missing out on a good percentage of our body. And then again, 10 to 15 minutes seems to be enough. Now, after that, if it's working, I do have plenty of people who continue to do it every night. Magnesium also helps with people sleep because of that calmness effect. So, the most effective dose is really doing it every night. Now, I do have some people who find that they get benefits for doing it a few times a week. So I'd say there's some variability with that as well, but that's my typical approach to it. Do you know of an alternative to Lexapro for anxiety and depression besides CBD oil and L-theanine if they are not working? Okay. Well, one of the things, of course, I always want to know as far as that last part of the question is how much is a person taking in the first place? Because there have been certainly plenty of times when I've asked that question when I'm asking a patient as to how much they're taking. And I'm like, well, I think I know why that's not working because you're not taking nearly enough. And as I've generally spoken about before, some people need up to 50 milligrams a few times a day for CBD. And I work adults and older kids up to L-theanine, even up to 600 milligrams twice a day. So that's kind of like the first thing. Now, um, what L-theanine does, among other things, is it boosts the production of serotonin, the release of serotonin into the synapse. Now, when people have to take medications that are like SSRIs, the serotonin reuptake inhibitors, what's happening in that situation is that the one cell releases the serotonin and then it tingles over here in what we call so this is the synapse in between. This is presynaptic cell. This is the postsynaptic cell. So it releases over here, it tingles on the serotonin receptor over here, and then it sucks it back up, reuptaking. And a serotonin reuptake inhibitor, what it does is it slows that reuptake of the serotonin, giving more time for the serotonin itself to be doing its action over here to send the signal that way. Okay. What L-theanine does is it actually puts more serotonin out into that synapse to hit the postsynaptic cell. And so it's a different mechanism of action, but it has a similar effect of increasing the amount of serotonin there to hit the next cell. Okay. Now, one of the things that I will also that I'll do if a person is seeming to need more support there is I'll add 5-HTP, which is 5-hydroxytryptophan. And 5-hydroxytryptophan is the specific precursor before serotonin. So there's tryptophan, then 5-hydroxytryptophan, then there is serotonin. And so by giving a building block, so it's kind of like almost you can think of it as like build the building block is the 5-HTP, but the construction worker is the L-theanine. So and sometimes they do work very well together. Now, in addition, on the CBD side, and of course, THC can have some very calming anti-anxiety effects as well. But one of the other minor cannabinoids that I'm using now is called CBG, as in George, CBG. And CBG is actually the mother cannabinoid made by the cannabis plant. So it first makes CBG, and then CBG gets further converted enzymatically to either CBD or THC. But the CBG is non intoxicating and it's its own chemical. And the CBG itself has found to be quite helpful for anxiety. And I do also find that it can be helpful when done at the same time as the CBD. Now, I have also found that mixing both of those worlds together, so a lot of times the CBD plus theanine is a nice combination, or sometimes we have to play with that. Now, certainly there are so many other things that can be involved in anxiety. Similar to the depression because those kind of run in the same circles. We know that methylation, MTHFR, the use of methylfolate. We know that even higher doses of methylfolate by prescription strength called Deplin is actually an FDA approved treatment for anxiety depression. It's actually considered approved as an adjunctive, a combination therapy with SSRIs, although I have found that it can work without using SSRI medications as well. So that's something there too. There's some calming herbs that some people can use as well. Of course, sometimes even we know so much now about how mental health is also related to inflammation and gut health. So we should always be thinking, Does the person have the optimized microbiome? Because there's neuroinflammation that can be involved in these depression, anxiety types of symptoms as well. So, focusing on a healthy diet, healthy microbiome, fermented foods, low inflammatory foods, etc. That can also be an important thing. And as well as when I do deeper dives, I do find that certain things like candida in the stool, sometimes clostridia as well, that can also make anxiety worse, and getting those under control can make a difference. All right. Our 4-year-old daughter had an abnormal EEG last week. They told us that she will be at risk for seizures due to the EEG findings and recommends medications, either Keppra or Trileptal, and said it's up to us whether to medicate since she has not had a seizures in 2 years, but we couldn't forgive ourselves if she was left with brain damage for not giving the meds. I've had there's so okay. So first of all, so the part of that question here is, based on your experience, which med is safer for the long-term effects of a young child? Okay. Now, I'm going to talk about the safety. Obviously, effectiveness is very different, and of course, part of the issue here is what type of abnormal seizure activity is a person having, because there are different seizure medications that work on different types of seizures. But we're talking about this here too. In general, if you were to review the side effect profile, Keppra comes in better than Trileptal. There's not, I really ever. It's very uncommon for me to hear problems with Keppra. So I guess if there was just a binary choice and it was my child, I guess that's the direction that I would go. But obviously, there's just so much more to it than just that. But I would certainly say it sounds like the neurologist was like in contemplation of that in the first place. As far as other supplementations and things, so CBD has been very nicely studied at this point. We know that the isolate is FDA approved for certain types of these of seizure disorders in a product called Epidiolex, which is a solution. It's not an oil, and it's also sweetened with sucralose, which some people have issues with. But that is an isolate, and the FDA approval is at extraordinarily up to working up to extraordinarily high doses that I've never come close to using in my clinic. But I guess that's nice that the FDA has at least assessed it from a safety perspective. But I have absolutely seen people leave on very low doses of CBD, 10 milligrams twice a day for full adults, completely stop having seizures. So that is an option as well. And again, coming back to inflammation. So neuroinflammation, whether it's on the mood side of things, but also there is an inflammatory component to seizure disorders too. So the types of things that help minimize inflammation, especially gut inflammation, other approaches, that too can be helpful in kind of reducing that seizure potential, because the more irritability through inflammation that's happening in the brain, then the more likely that one's cup may runneth over. Um, and do you have any other advice? Well, first of all, it's really important to be working with a healthcare provider on this. Obviously, this is something that I, as well as my other providers in our clinic, do. I do want to point out that, of course, this is not specific medical advice for one person. These are general advice, and really being under the medical observation and recommendations of a physician or other healthcare provider is super important for these types of things. And of course, if one is looking to look for a root cause biomedical approach, then talking to a provider such as myself, who can kind of get that down to that and has all of these other types of more natural approaches, can certainly be helpful so that you know as much about what your options are. Okay. With the new polio case in New York, it's making me consider the polio vaccine for my 2-year-old daughter, who currently has had no vaccines. What are your thoughts and opinions about the current polio vaccine, and what guidance do you offer? Okay. So, of course, whenever we talk about any medical treatment, we always want to say, what is the potential risk versus what's the potential benefit? Now, I will say that of all of the vaccines that a child can get, it does appear as if the polio is the one that causes the least side effects. Whenever I meet a family, if they're telling me that they're vaccine hesitant or have a vaccine problem, of course, I don't say to somebody, "Do you think vaccines cause your kids autism?" But I will ask a question such as, "Do you think anything particular triggered your kids' autism or other symptoms?" We've had certain POTS and all these other things, PANS, I should say. But a lot of time, and if they say, "Oh, I think it was vaccine," I'll say, "Do you know which one you think it is?" Polio vaccine is actually the one I almost never hear of a complaint of. It does seem to be the least reactive. Okay. Now, in this particular case, in this person in New York, this was a polio subtype 2, which doesn't really exist on the planet anymore except in the oral polio vaccine. Okay, so originally the vaccine, the Salk vaccine, was the injectable form, and then it moved into the Sabin oral form, which were sugar drops or cubes, which would use. And the advantage of an oral form, since this is a fecal oral infection, is that it would be much more stimulatory, go through the GI tract, create secretory IgA, and it was an incredibly effective treatment in stopping polio. The issue then became, once polio pretty much became worldwide eradicated, is that there were 8 to 10 kids, patients per year, even can be adults also, who were actually catching polio in America from the oral vaccine. Okay, because of fecal oral diaper changes, etc., soiled laundry, etc. And so the decision was made, hey, if there were more cases of polio from this vaccine than from the wild disease, we need to reassess what's going on. And so I do want to give the FDA and the CDC credit because they did make that change happen. Now, because the polio oral vaccine is more effective, though, which we don't really need that level of effectiveness here, but in third world countries, it is still being used. And so, what appears to have happened here is that there was a foreign travel situation. And on this particular person, it sounds as if, and again, we need more information, but it sounds as if there was another there was a foreign travel who may have infected this person, and that's where it happened. Now, fortunately, because this is a vaccine strain of it, usually it's not as serious as like wild polio in the first place. But coming back to like what's happening now, and actually, you may have heard about a few weeks ago how there were some polio cases found in sewer water in England, and it is felt to be from the same reason, oral polio from the vaccine. Okay. So if somebody says to me at this point in time, that doesn't mean that we may not learn about more things in the future where this does become more widespread. Do I think any one individual is more at risk of catching polio today than they were a month, a year, 5 years ago? No, I do not. Okay. So, obviously, the more people who are vaccinated, the less likely things can spread. But at the same time, how dangerous is the disease? How likely is it to be spread? How likely is one individual person to do it? That's all part of the decision making process that people go through if they start doing the research on vaccines. As you probably know, in my office, we believe in the individual rights of a parent or a person as an adult to make that decision for themselves. And I go through all of the different vaccines one at a time so that people can make the best educated decision for themselves. And then they'll say, yes, I wish to have this one. Now, I would honestly admit I don't get a lot of people who do decide, if they're not doing everything, who decide to do polio, and almost nobody decides to do it first unless they're traveling to a polio endemic area. So if they're going to certain parts of Africa or certain parts of Asia like Pakistan, Afghanistan, then there's a little bit of potential more risk there. But in terms of outbreaks in America, and this one case you certainly cannot call an outbreak, but there hasn't been an outbreak this millennium in our country. Okay, I think it was 1977, if I'm not mistaken, that the last significant outbreak had occurred. So, certainly, if a person does choose to do the vaccine, we do incur. My recommendation is always to do it when a person's as healthy as possible, when they have good vitamin D and zinc levels. Our immune support protocol is the same thing that we use for our vaccine support protocol in terms of the supplements that we give before and after. I am over 60 years old and I have been fully vaccinated against COVID and got 2 boosters. If I catch COVID, what is the guidance for seeking out one of the 2 antiviral available through prescription? Okay, so there are, although if you've been following me on the channel, you've heard me only talk about Paxlovid, except the very, very first video that I made about oral antivirals. Previously remdesivir is which is a IV form of an antiviral, but then became the oral forms that can be done as an outpatient, which of course was much more super convenient as well as much more readily available. Now the Paxlovid, that's the one that you hear me talk about. That's when you hear that much about. There is a second one called Molnupiravir. They're all weird discussion, but Molnupiravir. Excuse me. Now, as I had discussed in that first video, it's significantly less effective than Paxlovid, and it's 4 pills twice a day for the 5 days as opposed to 3 pills twice a day. And I kind of made the decision back then because of both the fact you'd have to take more pills and it was less effective. I kind of made a decision. I wasn't going to even bother talking about it more on the channel. If somebody asked me about it, as you are, I'm certainly happy to talk about it. But I guess if it was not available at Paxlovid and somebody really needs to do something, I guess they would do better than nothing. But Paxlovid is so widely available now. It's actually free even for people who don't have insurance. But, the government is paying for it now, so the availability is there. I have found it to be incredibly effective. Almost everybody who I know has taken it within 24 hours has really turned themselves around, and has stopped anybody from getting more sick. There is the side effect of some like GI upsetness. Some people get nausea, some people get a weird taste. I've had a few people get diarrhea from it. I have had a few people who did stop it because it was so nasty for them. But I've had a lot of people who have had almost none or no side effects from it whatsoever. So I do think that unless there's a specific thing, so there are certain medications that should be double checked across, like statins being one of them, that should be paused while going through this. Certain other medical conditions. Pregnancy is a question. It's an absolute contraindication for the molnupiravir. It's considered general for the Paxlovid, although there's a little bit more wiggle room there. But there are other medical conditions, and since this is available by prescription, the person who is prescribing it obviously should have that type of information available. If they don't, then they really have no business prescribing it in the first place. Okay, so at this point in the pandemic, what are your thoughts about an elderly person getting a second COVID booster, as in the fourth shot? I've heard that getting a booster now doesn't address the BA.5 variant at all. On the other hand, I have heard it does boost the immunity that wanes quickly. If this is true, why get it? Does it have any longer effect on protection from serious illness? Okay, so that's a lot of good questions there. First of all, I steadfastly disagree that there's no point to it, and I steadfastly disagree that it doesn't address the BA.5. There's been research that has come out actually in the even in the past week. Our Dr. John Campbell actually did a report on this just the next 48 hours, and I'm going to elaborate this on a little bit more, hopefully in another video. But here's the early information. First of all, it absolutely is giving a boost against BA4, BA5, especially in terms of more serious infections. Okay. I've talked freely about how my parents, who are both elderly, they, they did prior to our cruise take a fourth booster 2 weeks before the cruise, figuring that within 2 weeks the antibodies kick in. My dad at the end of the cruise caught it. My mom a couple days later, probably from being around my dad, caught it. Started them on, and they never developed anything but like some mild cold, mild cough symptoms. Certainly not nearly the type of fear that both as high risk individuals that we would have had a couple years ago. Now, because out of overabundance, because of both of their health conditions, we did eventually start Paxlovid on them. My dad was about 3 days into symptoms. My mom, being just off of chemo, we didn't take any chances with her. We just started her on it. But even during that first day, it was just kind of like cold symptoms and coughing. And that's kind of what I have been seeing for people, especially if they've gotten their fourth booster shot, or the fourth shot, the second booster, I should say. Um, Yes, it's true that immunity does wane quickly as in over the course of months, but it's not. So, first of all, there's a couple things to take into consideration here. First of all, when you're talking about the antibody levels specifically, and we talked about the SARS-CoV-2 semi quantitative total spike antibody, that's the test to get, those numbers do fade over time. They don't go down to zero. They're still there, but we certainly do see them gradually decline. But that's only part of the immune system. Now, antibodies for everything starts to decline for every infection. We can't just have antibodies staying full strength for all of the infections that we ever see in our life. We'd have only antibodies. There'd be no room for serum if that was the case. So so antibodies are supposed to fade over time. And to a protective level, that's what we don't know for this. However, there is the cellular immunity. Okay. So we're talking about the B cells and the T cells, the memory cells, the cells that are made to crank up the production of antibodies as soon as our immune system sees an infection again, or in this case, more the antigen, because the spike protein is the antigen that stimulates the immune system to create the antibody response, and that's what's kept in memory. Okay. Now, in addition to this, since we're talking a little bit about immunity, the younger people, especially the children, they have what's also called the innate immune system, which is a more general system. It's not related to specific antibodies, but its job is to recognize virally infected cells through things like natural killer cells. And the innate immune system is highest when we're the youngest in our toddler age, and it does gradually decline as we get older, to much significantly lower levels when a person is a senior. And that is the reason why we suspect, especially for COVID, why the older one gets, the more likely that it is a dangerous disease, especially in someone who does not have any prior exposure to spike protein, which, of course, as we talked about before, can be exposure via a vaccine or via the wild virus itself. Um, but as yeah, okay, so yes, it definitely does seem to protecting about serious, and the research is clearly showing this. That there does continue to be, against serious, hospitalization numbers way down, slight uptick that we've seen in the BA.5, but a very slight uptick, nowhere close to what we had seen with previous waves. Okay, as well as in deaths as well, numbers continue to stay low. Thank God. I looked, the most recent numbers around 200 to 300 deaths per day, which is obviously a lot. Every life is sacred, but what we were seeing, what, 10,000, deaths a day when it was at its peak, which was, of course, just incredibly, incredibly sad. So yeah, it does really seem to make a difference. Obviously, it's everybody's choice. We are anticipating come around November that the updated version of the vaccines that is supposed to cover for Omicron, and in particular, the early studies is that it is covering again, as far as coverage against the BA.4, BA.5s. Fair question to be asked is, will we be on to another variant, a Greek letter in the alphabet, or a BA.7 or BA.8 or whatever, and how protective will that be? Versus how much immune escape, these mutations in a spike protein bring immune escape, so that those antibodies are not as sticky to the spike protein as they previously were from both disease or from the vaccine. Okay. I know that you use probiotics with many of your autistic clients, my son being one of them, in the past. What is your take on prebiotics only, no products, and specifically in relation to the Nemechek protocol? Okay. So there's a little bit to unpack there. So, first of all, I no longer universally recommend probiotics to everybody. Okay. I use it in certain circumstances. If a baby was born via C-section, or if a baby had the mom had been exposed to antibiotics from an infection, group B strep at something, or if the baby required antibiotics in the newborn period, probiotics can be helpful. Although I also talk, especially if it's a baby needing the antibiotics, what we call vaginal seeding, the use of the vaginal juices that have the flora, and actually giving it to the baby around their mouth, in their mouth. Sounds gross until you think that that's what the baby's passing through if they had a vaginal birth in the first place. So that is one of my considerations. And of course, if an older person is taking antibiotics, not just the bacterial good flora, but Saccharomyces boulardii, in order to stop Candida, Clostridia, etc. growing. Okay. But one of the things that I have been focusing much more on the microbiome are fermented foods. The yogurts, the kefirs, kombuchas, the kimchis, pickles, sauerkrauts, etc., and trying to get as many of those into the diet as possible, because each of those different types of foods are more specialized in particular types of flora, and we want to have the most diverse flora possible in our gut. Now, prebiotics. Prebiotics is a type of fiber that is there as a food source for probiotics, or flora, I guess I say, just the natural flora, to help them grow. It's a food source for them. Okay. Now, some people taking prebiotics can get gassy because of the fermentation that happens of that food source. Now, as far as the Nemechek protocol, which also involves the use of omega-3 fatty acids, olive oil, and a few other things, I've seen it work for some people. It's been hit or miss. In looking at what it is, it does appear to be an incredibly safe thing to do, as well as not an overly difficult type of thing to do relative to some of the other protocols that are out there. So, as with so many things, there's just not a one size fits all type of approach for everything, especially for autism. A running joke, a couple of decades ago when we started with this in our movement was like, if you've seen a kid with asthma, you've seen asthma. There's mild, there's moderate, there's severe. If you've seen a kid with autism, you've seen a kid with autism, and the next one in the door can be completely different. And realistically, with the exception of a couple twins, Every single child with autism I have ever met has been different. So if the protocol works, if one wants to give it a try, I know it's readily available. The information online, the products themselves are very available online. And I really have no problem with the person trying it. Giving it a couple months, seeing if it makes a difference. We have a 7-year-old girl, overall healthy, going into first grade. She was potty trained at 2 to 3 years old. She is still wearing pull-ups and pees everything in them. Okay. We switched to not using pull-ups, no nighttime drinks, and taking her to the bathroom to pee before bed. Every night she pees in the bed at least one time. She does not have accidents during the day or during naps if she takes one. She sleeps from 9 p.m. until 7 a.m. What advice can you offer? Okay. So, because of the fact that this is happening specifically at night, the likelihood that it's something like a UTI or some other bladder abnormality is pretty unlikely. Sometimes, although more likely it's not just at night, there was no mention of the bowel patterns. A person who can have a full bowel where the rectum is pushing and the distal colon is pushing up against the bladder can cause it more difficult for someone to maintain their fluids. Is it possible at night because they're obviously sleeping that they may not be as aware of it and it's allowed to go? That's a possibility. So it's always part of my history taking. But usually when this is happening, it's because the patient is in a deep sleep and they don't get the signal from their brain, hey, wake up before you pee, like a lot of us do, or that even that sensation that we all feel during the day. Now, there wasn't mentioned specifically about when fluids were being cut off. Sometimes, right before bed. Sometimes it needs to be even like don't nothing before, after dinner or that type of thing. That's an important. But there are other types of things that I do employ. One of the most helpful things is what's called a bedwetting alarm. Okay, and there's lots of different devices. I think I'll give a free plug. I think it's thebedweddingstore.com or something similar to that, where they have all types of ones that some of them are vibration, some of them are loud sounds, some of them have both, which I think if you're buying a unit, might as well get both. But what the common thing is that they all have a sensor that goes right near where the urethra is, in that part of the underpants. And the moment that there is a first sense of moisture, the alarms go off. And what that does is it's supposed to, God willing, wake the person up. They feel the full bladder. They're able to get to the bathroom, but also there's a little bit of a Pavlovian response. Pavlovian response is, every time the dog hears the bell, they'll do something, and then eventually, then they can do it without the bell because they get the signal. But in this particular case, the feeling of waking up with a full bladder and going to do something can sometimes almost like reprogram the person to just have the signal of the stretched bladder be enough to make them then wake up without the alarm over time in order to get to the bathroom without having an accident. Okay. um, the there are a couple other things that I do. We talk about mind over matter. Okay. Whether people do meditations before nighttime, whether they do prayers before nighttime, some of the things that can also be helpful would be as part of that nighttime routine for the person to like maybe 10 times say to themselves, I'm not going to pee the bed tonight. I'm not going to pee the bed tonight. I'm not going to pee the bed tonight. With lots of things in life, when we say it enough times, we can manifest it. Okay. So that's part of my P protocol overall is like, just trying to accomplish that. Um, you know, i- Usually if those types of things don't work, sometimes a urologist, can maybe have some other things or may need to do some kind of bladder scans or anatomy scans just to make sure that there's nothing going on. But the way it's being described now, I don't know if I'd use the word behavioral because obviously behavioral is at least I don't know if call it intentional, but mindful aspect to it. Whereas, of course, this isn't a behavior per se. If a person's sleeping, you can't really pick your behaviors while you're sleeping. So hopefully that helps. We have not been able to meet with our overseas families for years and plan to visit them this October 2022. My 31-month-old baby has not received any vaccines. What measures might you recommend we take when traveling overseas with her? Does she need to be vaxxed, or do you think we might be able to manage raising an unvaxxed child? That's a question. Okay, so in terms of certainly there are people in this world, certainly there are people in our practice who have gone on to adulthood who have not been vaccinated. So vaccines certainly do provide protection against the disease itself that it's made for, but I do get frustrated when I hear a say your kid needs these vaccines. Okay, I have no problem if a doctor says I recommend these vaccines. I think it's foolish if you don't give a vaccine because of the risk you're putting your child in. You're putting your child potentially at risk. Those are statements based upon information. But to me, need is a different thing because you need love, food, clothing, shelter and water. Everything else you don't need per se, right? Oxygen. Did I say that? But again, stating that you need something is a subjective statement being couched as an objective statement, and I think that that's an overstep. Okay, and so when I talk to people, I talk to them about the relevancy of vaccine to vaccine, and then putting together the pro versus the con. Now, one of the things that I will counsel people on is wherever you're traveling to, find out if any of the vaccine preventable diseases are in high levels there. Um, the health departments of individual counties have that information. Contacting the health department of the region where you're going to. So obviously, if somebody says I'm going to Russia or I'm going to China, where we're talking about huge land masses, what's happening in the west, it can be 5,000 miles away from where the nearest case of something is. So contacting that local health department to find out if what particular disease is around, that could of course give a person some more guidance because again, part of that risk versus benefit. Okay. Now, in addition to that, again, some of our standards, having good vitamin D levels, having good zinc levels, in a flying situation where they're around in the airport and on an airplane, we actually do it similarly to the way we do with our vaccines, using our immune support protocol before and after the flight in order to do that. Of course, if a person was exposed to somebody, and that's true not just for a vaccine preventable disease, but any disease, starting our immune support protocol as soon as humanly possible for that as well. And so, again, that's how I would kind of answer that question, and kind of taking that individual's approach, and of course, having a more one-on-one discussion with whether it's one of us or another trusted healthcare provider can potentially give you more information and food for thought to kind of weigh that risk versus benefit. I'm curious about the meningitis vaccine and the strains that it currently covers. Can you discuss in detail the coverage that kids get now, and whatever is out there that is not being covered? Okay, so first of all, this needs to be further delineated. Okay, meningitis is an inflammation of the meninges, which is the membrane that surrounds the brain and spinal cord, and it can cause some very very serious. This could be one of the most serious types of infections that a person can get in terms of having long-term implications neurologically, deafness, um, and can even be fatal, depending. Now, most meningitises are viral, and there is not a vaccine for them. Viral meningitises are often less dangerous than the bacterial ones. So that's first to start. Now, it also depends on age groups. Okay. So in babies, young children, toddlers, the more common bacterial meningitis, there's two: Streptococcal pneumoniae and Haemophilus influenza B. Both of them have specific vaccines, the Hib vaccine and the pneumococcal or PC or Prevnar vaccine. There's a couple of different Hib vaccines as well, but those are targeted for those. They're typically, they're given up until 5 years of age. They're not even given after that point, unless there's some immunocompromise or other. Now, Haemophilus influenza B, I have never seen this since leaving my residency. So this has been a not yet this millennium type of thing. Okay. Streptococcal, and that's of any force. Now, Haemophilus influenza B can also cause what we call a periorbital cellulitis, where it can quickly take over the skin around the eye and can invade the eye. That's a terrible thing. I've never seen any of this, or sepsis. It can cause sepsis as well. Now, Streptococcal pneumoniae, much more commonly, this causes an ear infection. It doesn't cause meningitis, but it can cause sepsis, etc., as well as meningitis. Now, I have a suspicion, though, that what this particular question is about is against a particular bacteria called Neisseria meningitidis. Okay. Now, this is something that vaccines are not given to young children. It's something that is given to older children. So it is, these are things. Now, there are two different vaccines. Okay. And there's a couple different versions of each. One is called is the meningococcal that targets groups A, C, Y, and W. Okay. And this is something that the CDC is recommending to be given to older kids, as well as to, and if not done beforehand, as a single dose when somebody is going into college in like a residential dorm type of situation, or people who are going into like the military and are going to be in army bracket barracks. That does seem to be the higher risk for an otherwise healthy individual. Those do seem to be the more at risk individual. Now, in addition to that, there is the meningitis, which is called Group B. Now, this is something that first of all, it's not something that is being universally recommended by the CDC. The CDC says you can get it, you may get it. It's the wording such as that, as opposed to the should word, which was being used for the previous one. But there has been and some outbreaks going on this year, and in Florida in particular. Now, the population that it has been hitting in Florida is actually in gay men. And as with what we've talked about previously with monkeypox, this is not a gay disease, just like um, HIV was not a disease of gay people. It is passed along by close spread. And so, if there is within a particular population more of a given disease of whatever it is, and there is close contact with amongst that group, it is more likely to spread. Okay, so please do not be saying this is another gay disease. I mean, like that's baloney. I reject that completely. But that is what that's about. And there is the vac, and if certainly if a person is in that higher risk group, similar to how people talk about how there is the vaccine available for monkeypox in the high risk group, that's where a person may get more benefit. But again, it's not something for young children, and it's not even that one's again not even something that's considered universally recommended. Okay. My kid goes up and down with his development. Some days he forgets the words that he knows and he is just thinking about the answer. Is this normal? Would you recommend to see a neurologist or other medical professional? Unless a kid is playing you, this is not normal. Okay. You should not be forgetting the words. Now, I realize that there are some kids, even for attention, control, will do these types of things. I knew somebody growing up who even developed what we then kind of called a pseudo paralysis, where she said that she wasn't able to walk. And then finally, it was kind of just brought to her attention. Everything is perfectly fine. I think you can get up and walk. And she did. Okay. Now, so of course there is that pseudo aspect of things. I don't know anything else about this child's development, but obviously if there are other developmental flags and behaviors and then or and in social skills, sensory skill issues as well, of course, the more other things, the more significant it is. But no, a child should not be losing their words, even if it's a come and go type of thing. Now, what are some of the things that I would think about in this particular individual? Okay, I would be wondering if there is anything variable throughout the child's week, that maybe a child is having an exposure to something, keeping a dietary food log. Maybe this is happening 24 hours after somebody has corn. I don't know. Um, or maybe this is something that happens after they go to a particular place. They go to karate, they do their gymnastics, some type of indoor mold or other type of environmental toxin. A patient of mine, talking about 15 years ago, he started having seizures every Monday. No problems with us every month. Pardon me, it was every other Monday. And deeper investigation found that every other Monday in their classroom, they were doing a deeper clean with much harsher chemicals than they were doing for the more routine cleaning. And we discovered this, they changed this, they stopped using it, and the kids stopped having seizures. So that is a perfect example of a neurological condition that was brought on by some type of exposure. So do I think that a person could take some time to kind of do a little investigative work on their own to see if there is some type of something that's stimulating this from happening. But if that's not triggered, I would absolutely get this the child evaluated, not just to see about this. Are there any other more subtle neurological, developmental, behavioral other issues that may be more of full spectrum? Of course, in our world, looking to see if there's any other things biomedical. Oh, I guess another thing I would say stress. Sometimes a stressful situation can bring on more neurological symptoms, not just internal stress and stress on the kid themselves, stress in the household, maybe, our parents fighting, or is there something else going on? Or are they watching some particularly stressful or anxiety provoking movie or video game? Some of the video games that kids play that can invoke anxiety in anybody. But, some type of external stimulus would be something that I would be thinking about. But if we're not finding that, then again, getting a further evaluation from a neurodevelopmental perspective, getting looking deeper and from a biomedical perspective, that would be the approaches I would take. Hi, Dr. David. I was on last night's True Leave Physician Connect call, and I was really blown away by a few discussion points. One main question is, what are your thoughts on dosage for my MMJ patients? Well, I don't know who you are, but do you have any ideas why the OMMU doesn't have any outlets for new physicians with their certification for dosage of patients? Okay, let me address the OMMU first, because this was actually something, the first time that we had to get certified. So this is going back to 2016. There was a 6-hour course that did go into not just how do you put a person into the registry and who's eligible, but there were some dosing strategies that were discussed during and unfortunately, the legislation loosened to it just being a 2-hour course every 2 years. And all we have to do now is take a course on learning who is eligible to be put into the registry and how to do it literally page by page. This is how you click through, and that's the 2 hours. So unfortunately, that's to me that was unfortunate, because there should be some type of oversight, certain level of proficiency. If you're we have, I certainly, as a pediatrician, I have to take certain pediatric courses, I have to take my pediatric boards. Any physician in the state of Florida has to have a certain amount of continuing medication education, CMEs, in order to even maintain their license. So it sure would have been nice if there would have been some education on this, but now it's really about self learning. Okay. There are certainly great textbooks. There are online and in person conferences and webcasts and such, but it really has to be a self exploration itself. Now, in terms of thoughts of dosage from patients, as I've talked about before, I've always just taken a low and slow approach. I have adults who are taking minuscule amounts compared to large dose for children. So, my rules of thumb include starting with non-intoxicating form, i.e. CBD or CBN if there's a sleep issue, CBG if more anxiety issues come up, CBGA if there is inflammatory issues, before bringing any form of THC in. Secondly, of going slow and making a change every 3 days, because that's kind of how I teach everybody. Is, even though the effects of any cannabinoid is going to be felt in the first day, the first dose, I always like to make a change every 3 days, because maybe the person had a particularly good or bad day. So 3 days should kind of be a wash in terms of understanding what's really happening with that. Making one, increasing the dose gradually, and again, depending on the product, depends on how I would increase the dose, and kind of maxing that one out before bringing another one in, and then bringing another one in, and again bringing that up. But don't make more than one change at a time, right? But in terms of individual dosing, it really depends on the person. If I'm introducing THC to somebody, I'll generally talk about, if it's a very young child, maybe making jumps of 1 milligram, an older kid, or a treatment naive, an adult who never has had it before, 2 milligrams. But somebody who's had life experience with using THC, um, and they know what they're doing, but they want to figure out a therapeutic dose, then maybe starting at 5 milligrams and making jumps of five and kind of seeing till you get the effect. But certainly, of the thousands and thousands of people that I have, that I'm currently their cannabis doctor for, I know for a fact that there's not any two people who are doing the same thing. And of course, for some people, routes of administration are different. Some people respond better to oral versus inhaled form. Some people like the patches for that more micro dosing, slow effect.
And of course, we even talked about, the different strains and the use of terpenes and trying to figure out which terpene profiles may match particularly the individual best. So I hope that that does help you, though. I was kind of joking, obviously not knowing you because I wouldn't announce anything here, even if I did in that kind of forum. But yeah, hopefully that helped you out. Our daughter has double cortex syndrome, has had lots of increased seizures lately, especially over the summer. We have started giving her a small amount of THC, which seemed to have helped at the beginning. She is taking CBD, Epidiolex. I don't know if that means CBD as Epidiolex because Epidiolex is CBD, and Depakote. She is also having a lot of more anxiety about everything and is becoming almost nonverbal. I wonder if storms could be part of the issue. Okay, I would actually be talk more about barometric pressure. Okay, we hear about pressure more like when there are storms coming, like hurricanes coming, because the barometric pressure drops. And I do have some patients who neurologically are impacted when the barometric, not bariatric, barometric pressure does drop. So, I certainly think, maybe wanting to follow those numbers because, AccuWeather and Weather Channel and all of them, they do put the current the ambient pressure is out there. So maybe seeing if there's a cutoff where it's coming, where it's more triggering it. That's something. Um, of course, being summer, if a kid's not in school, again, different exposures might that child be having. Eating different foods, during summertime, going to different places. Again, all of those types of things would also be something that I would be taking into account. But in particular, to your question about storms and the bariatric pressure, I have seen this enough, not often, but I have seen this enough to I think that it's not a pie in the sky idea that you are bringing up. Of course, the one challenge would be, it's not something that we can change the our atmospheric pressure about that. But could it be the type of thing that if we know a storm is coming, or we know that the in Florida that the storms tend to hit in the evening, could it be the type of thing that a type of treatment like I've talked about already for seizures may be more appropriate for an individual to do at a particular time preventively, prophylactically, in order to maybe try to prevent that from happening. Okay, do we have any more questions? Okay, last question. This is also from a physician. Do you have any idea if swab is a reliable test to do? I would love to see. So mitoswab. So let me take a half a step back for people to know. So mitochondria are the power plants for our cells and produce ATP energy. There's a lot of nutrients, pardon me, that are involved in having optimal mitochondrial function. Pardon me for 1 second, please. Okay. And so looking at things. Okay, so again, let me just kind of start it over since I was interrupted by my little throat dryness there. So mitochondria are the power plants of our cells, making ATP energy, and they provide cellular energy. It's not what makes you hyper as an energy; that's what makes us tick. Okay, and there are different complexes, complex 1, 2, 3, and 4, where the electron, it's called electron chain transfer, is happening, where it's and so and these different complexes have different nutrients that are needed in order for them to work. Okay, so what the mitoswab does, this is a test that's done by a cheek swab where they gather the cells, they're able to extract the mitochondria from the cells, and then they're able to assess the function of each of these complexes. And there are certain nutrients that if this complex is off or that complex is off, that may be more helpful. Okay. There have been anecdotal reports on this. I absolutely think that there does need to be more research done on it. Okay. It does seem as if, from what I can tell, that the information on complex 1 and complex 4 seems to be a little bit more solid than complex 2 and 3, but sometimes 2 and 3 are needed to kind of get into more unusual situations. I usually, a lot of times, depending on cost and availability, I'll do just the 1 and 4 and the citrate synthase. But I would love to have more information. But it's certainly something that it's not something that I do as a routine part of every one of my biomedical workups. It is something that I do if I'm not finding the answers that I'm looking for. A lot of times people who have mitochondrial conditions, they may have these crashes where they can be fine part of the time and then they just crash. And sometimes they crash hard. And different stimuli can make it happen. Viral infection can happen. Stress can make it happen. Temperature changes can make it happen. And so, I know that there are some people who talk about, using a mitochondrial cocktail, and there are products that have every single nutrient in the world that are related to it. But some people are sensitive and may not need all of those nutrients. So that's working up. So I kind of look at it as an aid, but I don't look at it as the end all be all slash primary thing that I'm doing. But it is something that I'm ordering, with, on some people just like for more information. Okay. And I think that does it. So thank you all for checking us out again. Check out our other videos again. Subscribe. Join us on our other million. I know we're close to 1,000 subscribers. Maybe you can all hop on and become number 1,000 for us. That would be great. It's important for us to hit that number. Also the number of hours. So watch what we're doing. Because there are some special numbers with YouTube that allows once we've hit these certain numbers that allows our videos to be found by others easier. The algorithm, it's bumped up the search engine. So, of course, not just for educating yourself, but if you think that the world needs to hear more about what we have to say here, which of course I do, that's why I'm doing this in the first place. Share it, get those subscriber numbers up, watch as many of our videos as you can, watch them a second time if you want. But seriously, that's what we're trying to do with this channel. Why we're doing this, I want to educate people. I want to give people a way of thinking about things differently. I want to have them put new ideas in their mind, things that maybe nobody has had of. At least once a week, I've had somebody said to me, nobody has ever asked me about that. Nobody has ever suggested to that before. And that's what I'm wanting to bring to everybody out there. So thank you very much for joining us and have a great day.